Good afternoon, everyone. I'll be dealing with the innovative diagnosis, the future of detection in keratoconus. There is no financial interest. Why do we need a better detection of keratoconus? As she described, there is a rising prevalence in the keratoconus patients, especially in the Southeast Asia and the Middle East. And there is a refractive surgery boom. So we need to detect all cases of keratoconus, especially the subclinical cases, to prevent any post-refractive ectasia. And the goal has shifted from identifying disease to predicting risk factors. So in the diagnosis evolution, we have in the first description of staphyloma diaphanum, we have moved across to the placidodisc methods, to the computerized TeamFlux imaging, to the Corvis ST bad displays, and finally in the new era of AI and multimodal imaging in 2015 onwards. So the traditional imaging by Helmholtz-Schwarz, they were able to detect the distorted mild steep cornea and the high astigmatism, but the limitations were they were measuring only the 3 to 4 central mm of the cornea, and when the keratometry exceeds more than 55, they could not detect any cases of keratoconus. So as in the first case, you can see that these are the cases which we like to miss on a clinical slit lamp examination. These needs advanced imaging techniques. So corneal topography or tomography techniques include the Placido-based ones, the Placido disc, video keratography, the slit scanning system, the OpScan, TeamFlux imaging, the Pentacam, Sarath, and the Galili. So what is the difference between tomography and a topography? Topography just analyzes the surface shape and the features, whereas the tomography gives a three-dimensional imaging of the cornea. So these are the conventional topographic screening parameters. I'm not going to into details of these parameters. So we'll move on to the OpScan. OpScan is based on the slit scanning technology. OpScan 2 is the latest version. It measures the anterior corneal curvature indices, pachymetry, focal elevations, depressions on a computer-generated best fit sphere. So this is an example of a OpScan image. You can see that the anterior elevation, posterior elevation, curvature map, and the pachymetry. When you screen, these are the cutoff values which you have to remember. The mean keratometry more than 46.95, inferior superior asymmetry more than 1.2. The posterior float more than 42 microns, a difference between a difference of 50 microns, and the irregularity, any irregularity in the central 3 to 5 mm should be suspicious. And distance of the corneal apex and the thinnest location shift more than 0.9 millimeter should be suspicious. Any thinnest point less than 470 also should be a suspicious value. So Pentacam, the most modern one, which is based on the TeamFlux imaging. As you all know that the object plane, the film plane and the picture plane coincides at a single point of intersection, which gives an advanced imaging modality. So you can see that there is the first quad map. You can see the sagittal curvature map. Then you have the pachymetry map, elevation map, anterior as well as a posterior. So in the sagittal curvature map, you have to look at the keratometric value where there is steepening or not, and the simulated K values, which is less than 47.2 is a normal value, more than 47.2 should ring a bell. It is a case of suspicious keratoconus. And there is skewing of the radial axis, which is if it is more than 22 degrees should be a suspicious case of keratoconus. And the inferior superior asymmetry, especially the steepening in the inferior part, should be suspicious. If it is less than 0.8 or if it is more than 1.2 or 1.9, you can say it is suspicious of keratoconus. Thickness map, as such, you cannot say that only thinning is not suggestive of keratoconus, but the shift of the thinnest location as well as the thinnest point from the apex more than 10 micron is suspicious of keratoconus, as well as thinning along with steepening is diagnosis of keratoconus. And Amsler Krumich have staged keratoconus based on the steepening, myopia as well as astigmatism, and whether there is corneal scarring or not. In stage 1, there is myopic astigmatism less than 5 and eccentric steepening. In stage 4, you will get keratoconus scarring, central corneal scarring along with a thin cornea of 200 micron. So any of the criteria, if it justifies, it falls into that category or stage of keratoconus. Elevation maps, in the anterior elevation map, if it is more than 15 micron, it is suggestive of keratoconus, and normal value should be less than 12 micron. And posterior elevation value, if it is more than 20, is suggestive of keratoconus, and less than 17 is normal, and 18 to 20 is a borderline case or suspicious case of keratoconus. Any difference between back and front surface with plus 5 micron also is suggestive. Next, Bellin-Ambrosi enhanced display. Here, the best fit sphere is being made by excluding the central 3 mm point around the thinnest location. So it gives a D value. D value comprises of 5 parameters: the front value, back value, pachymetric progression, thinnest point, and the shift of the thinnest location from the apex. So D value, total D value, if it is less than 1.7 is normal. Anything more than 2 you should suspect keratoconus. If it is more than 2.6, it comes in the red value, it is indicative of keratoconus. As you can see, it is color coded, so anything in the yellow or red should be suspicious or clinically diagnostic of keratoconus. Next, Bellin described the ABCD grading system, where the anterior corneal curvature, back surface, corneal thickness, as well as the corrected distance, visual acuity were taken into account. Here also you can stage from 0 to stage 5 based on these parameters. And next would be a percentage tissue increase in normal cornea from the central to the periphery. There is a uniform thickness happening from the center to the periphery, or as you progress from the periphery to the center, there is progressive thinning. So apex should be the thinnest. It has to fall in the 2 standard deviation of this graph. So first would be it has to come in the central value. Any steep or any abrupt changes should be suspicious of keratoconus. So we have the advanced modalities. You have the Pentacam HR, Pentacam AXL, Cassini, Galili, and Sarath. The first two are based on the Schimflug imaging. Cassini is based on color LED topography. Galili has dual Schimflug along with Placido based the classical topography along with Schimflug. And Sarath has single Schimflug plus Placido disk. Cassini is based on the ray tracing. In the Cassini, we have a Cassini report like in Pentacam. Galili, what you have to remember is irregular astigmatism index of more than 0.45 or a standard deviation more than 1.065 or a surface irregularity index more than 0.735 is diagnostic of keratoconus. Sarath also gives a report like in Pentacam. You can see here what you get a keratoconus. Finally, you have a diagnostic report also, whether it's keratoconus compatible or if it's a borderline topo or a normal topo. But you have to be cautious in interpreting this just value. You have to go to all the maps, whether it's a proper keratoconus also, okay, because sometimes you can have a fallacy or a error report in these cases where there is thinning but no steepening or anything. And next is epithelial mapping. In a normal patient, you have a donut sign which you can see, that is in the central area where there is thinning, there can be epithelial hypertrophy which can get masked in a case of keratoconus. So this is also important in case of keratoconus to diagnose. As you can see, there is a thin area where you can see a paracentral area with a epithelial hypertrophy. So this may unmask in a case with a anterior segment tomography. And Corvus ST, finally, it gives a biomechanical index where there is deformation with a puff of air. So biomechanical properties like CBI, the Corvus biomechanical index, tomographic biomechanical index, as well as the Pentacam bad display also will be there. Any value of CBI more than 0.5 is suggestive of keratoconus, or TBI value more than 0.75 is diagnostic of keratoconus. Bad display, as I said, it is more than 1.6 is suspicious. And it gives a Vincigora report also. So the advanced modalities would be a polarizing sensitive OCT, then in vivo confocal microscopy, brilliant light microscopy, atomic force microscopy, optical coherence elastography. So these are the advanced modality which are still in research. And we have the molecular diagnosis, the tear film proteomic biomarkers, AI, as well as genetic or polygenetic risk factor analysis. So these are the future of keratoconus diagnosis. To conclude, I would say that the innovative diagnosis should include a combination of multiple imaging tools to enhance the detection, not just by a single topography or a tomography. So basic, you should have a topography, Schimflug imaging, and ASOCT. And other things which I have mentioned are the future directions which we need to work upon. Okay. Thank you.